one of the ones that we get into a lot of trouble with the orthostatic hypotension. And I think that's one of the most dangerous comorbidities in the elderly. And diuretics are used both in systolic and diastolic heart failure, and they should be used cautiously with diastolic dysfunction where maintaining an adequate cardiac output is heavily preload dependent in order to avoid syncope, falls, and confusion. When diuretics, then there's loop diuretics, and when they're used, serum potassium levels should be monitored due to an increased risk of hyperkalemia with potassium-sparing agents and of hypokalemia with loop diuretics. So a lot of people just think all diuretics are the same, but some cause them to hold their potassium, some cause them to lose their potassium. So a lot of people will go in and be diagnosed with hypertension for the first time and get on a diuretic, and within 2 to 3 weeks, 4 weeks, not only are they having lightheadedness, orthostatic hypotension, then they have electrolyte imbalances. They're restricting their fluid intake because they're peeing a lot, so then they're even more volume depleted, and now they have all these little problems where they just started with hypertension. So proper management is so important. Yes, like the use of diuretics increase the risk of sudden loss of urinary control, and that is very embarrassing to people, and a very common and potentially reversible geriatric syndrome. Then there's, in the same series that I told you about, there's a urinary incontinence assessment tool that you can use. And there's also a hydration assessment tool, because a lot of patients, to avoid the incontinence, like I said, will stop drinking. So those are two very good tools to use with your patient. Linda, do I have 5 minutes or 5 or 10 minutes? 10, okay, thank you. Because I wasn't looking, I have my reading glasses on and they're just from Walmart, so I can't see far away. Because I've been denying that I need them. I'm at that point. I need them. So nocturia, these symptoms may actually be present in the older adult from other coexisting comorbidities. And nocturia develops in patients with heart disease because of an increased vascular return when supine can precipitate a need to get up more frequently at night to urinate. And one thing that we can do to help you with this is, like, they lay down and all that fluid that's down there starts finally reabsorbing and they're peeing it out, is encourage them to take a couple periods during the day where they sit and put their feet up. Not just sit, put their feet up, so that hopefully they can get that fluid to reabsorb a little during the day. And so it's not, they're not having this urge to be up all night, because once they start getting up all night, then other things come into play, like do they have visual impairment? Do they have osteoarthritis of the hip and knee, making it hard for them to get up and walk to the bathroom? Then they have an increased risk of falling because they have to get their glasses. They don't know if they can get their glasses on in time to make it to the bathroom. Overall management considerations for the older adult with heart disease and the new development of urinary incontinence of falls include reevaluation of medication regime, activity tolerance considerations, and the use of additional adapted aids to minimize the risk of falls. So it could be very embarrassing to them and they're not telling you, but you could recommend a nighttime urinal or a bedside commode, you know, a scheduled toileting rounds, decrease their fluids after a certain time at night. Digoxin is another medication that is used. Also, like I said earlier, the dopamine and dobutamine, vasodilators. So in all the treatment that we give the patients, we want to teach them warning signs of heart failure or recurrent MI. So things you want to be aware of yourself or to encourage your patient to be aware of is chest pain or chest pressure, shortness of breath, indigestion, nausea, dizziness, palpitation, confusion, weakness, weight gain. And it's so hard because in so many people it presents in so many different ways, and when they're taking medications, usually if it's new too, then they have all these new symptoms that they're trying to figure out if is it from the new medication, am I blood pressure bottoming out again, or am I worsening and I'm developing worsening heart failure. So one good thing to do, especially if you have patients that live at home alone, is develop a rehearsal plan for obtaining immediate medical attention. And the value in this is so important because, like, I didn't even realize it. We always just go to our students, and then if there's a code, you do this, and you do that, and you do this. But then we had a code, and they were all just sick about it. So now we've added an actual mock code, and it takes that anxiety away. And if you do that with your patients too, it's like, well, this is what I'm going to do. And it may mean that they need to have a medical alert system in place if they do live alone. If they fall down and they can't get up. So this is a good time to talk to them about it. Do a rehearsal plan with them, and then it could bring up issues of you need to have a cell phone, you need to have a medical alert. Then there's the need to maintain certain cardiac medications. And it's vital since abruptly stopping them can be dangerous. All medications should be reviewed with the patient and their caregivers. Stressing, you want to let them know what the desired effects are, their common side effects, possible interactions with over-the-counter, what to do if the medications are actually accidentally omitted or become too costly to maintain. And that could be very embarrassing for people too. They don't want to admit that they can't afford to take their medication. So even just talking to them about what would other programs that are out there, what happens if you miss a dose, how important it is to stay on a regime. And that's why long-term management of heart failure requires a multidisciplinary team approach. You have to get not only you, their family, the pharmacist, everyone involved in the management of a patient. So there's a growing body of intervention studies that show using technology to improve adherence to prescribed treatments, to improve quality of life and reduce unplanned hospitalizations. And some of these, what they've done is they'll have nurse-centered calls where they call and check in on people and talk about their symptoms, their management, and how they're tolerating it. Also, they have reminder calls, and they have them tailored to the specific diagnosis, the age, and the cultural, and it's like an automated call, and they just call the patient every week or every day and give them updates. Or, did you remember to take your diuretic? Are you following a DASH diet? Are you trying to stop smoking? But they're just little reminder calls, and it's a connection to. And also there is a trial with nursing students to do the same thing where they call up and they do education and symptom management. And all of these have demonstrated a positive effect on the quality of life and the number of heart failure symptoms that are present in the patients that were involved in the studies. The only thing is that a lot of older adults don't like technology and they're uncomfortable with it, and it's not effective with them. So you have to assess whether your patient is receptive. If it's computerized emails that go out every day, my parents don't even have email or a computer. So you have to feel out how they feel about technology. And as we get older, hopefully we will accept technology, but it'll be something new that we're trying to be comfortable with. So nursing presence has been described as an integral component of a successful community-based care management program for older adults with heart failure. In addition, family caregivers of patients with heart failure have many needs for information and support. And like I said, I have listed a lot of these resources in the back that I got from the consortium in Philadelphia. And I have used so many of these, and they've been so helpful. So they're all listed here, but like I said, if you have other needs that you want or case studies, I have a lot of case studies that are really effective in problem solving and managing or getting people to elicit thoughts on their own. And does anybody have any questions? We had staff development just recently, and a woman spoke to everybody, and I was not there, but a colleague told me that after 20 minutes, you lose your audience. So I was thinking I could either talk really, really fast, which I already do, or I could stop at 20 minutes, but I didn't do either. So I appreciate your attention to this very in-depth topic that I hope I covered in enough detail for you. But like I said, I have many more resources, and I'd be happy to share them with you.